pretty full agenda today, and the meeting today was extended for an hour and a half. At the end of the program, we'll have a SHIP presentation with some updates, and all calls are welcome to stay on for the call, but definitely those that are involved in SHIP need to stay on to listen to the updates that will be provided. Okay, as IRHA indicated, please do chat your questions in, and there will be a SurveyMonkey link provided to provide some evaluation input at the end. Today's session, actually, the topics were selected based on our call convening meeting, Caring on the Crossroads of Indiana, that was held back in October. And so the behavioral health topics were selected since that was an area of concern. The State Office of Rural Health team members are David Conrad, who is the Flex Grant Coordinator, and Abigail Garcia, who's the State Office of Rural Health Manager. If you have any questions related to rural health or activities, please contact either David or Abby, and they'll be glad to answer your questions or research that for you.
That's probably why he...
On the agenda for today, first we will hear from David Conrad. He will provide a 2017-2018 Flex update. We will also be hearing from Greene County Hospital. They'll be sharing measures that they have taken within their facility related to caring for behavioral health patients. We will also be hearing from Jen Peterson, who is a social work supervisor in Minnesota at First Light Health Systems. First Light was recommended to us as a facility that has really done some progressive things in terms of working with behavioral health patients, particularly in their emergency rooms. We'll also be hearing from Janae Myers. She is going to present some information on antibiotic stewardship and some very unique Indiana resources. She works at the Indiana State Department of Health. I will be providing an MB Quip update overall. And then Abby Garcia and Karen Kennedy will be providing the SHIP update at the end of the call. So at this time, I'll turn it over to David Conrad to provide the 2017-2018 Flex update. David? David, I don't know if you're muted or having some problems.
I'll go ahead and unmute all of you guys so David can go ahead and get on the line.
Okay. Well, actually, if David's having some technical difficulties, I can go ahead and provide the update. There are some additional measures that are going to be required for MB Quip eligibility. Many of you are already submitting ED1 and ED2. ED1 is the median time from ED arrival to ED departure for admitted patients, and ED2 is, an inpatient measure as well. It's admit decision time to ED departure time for admitted patients. The first quarter of required reporting is the third quarter of 2017, and the submission deadline is February 15th, 2018. The ED1 and ED2 will be taken into account as part of the fiscal year 2019 eligibility criteria. So on February 15th, please make sure that your ED1 and ED2 measures are being submitted if you aren't doing that already. And there is some online training available, the MB Quip abstraction training for ED1 and ED2 measures. Additionally, NHSN annual facility surveys are going to be required. Many of you are submitting infection data into NHSN already, but there will be an 2017 NHSN annual facility survey. It's anticipated that the survey will be available the very first part of January 2018, and the CDC is encouraging all CAUs to complete the survey by March 1st, 2018. That's not a hard deadline, but that is highly encouraged that you do that. There will be an upcoming webinar to address the antibiotic stewardship information related to the annual facility survey, and it will be conducted on January 23rd from 2 to 3 o'clock Eastern Time. That will focus on completion of the annual survey, and individuals will also be available to answer any questions that you have about the survey, and I'm sure answer any questions that you have about NHSN in general. So be watching for more information related to the facility survey, and we'll be distributing it as it is available. Okay, so at this time then, I will stop sharing my screen and I will turn the presentation over to Jill Raines, Brian Woodall, and Troy Gaither at Greene County Hospital in Linton, Indiana. So Jill, I've stopped sharing. If you would like to go ahead and share your screen and begin your presentation.
Hello.
Okay, go right ahead. We can see your presentation.
Okay, great. So my name's Jill Raines, and I'm with Brian Woodall and Troy Gaither, our public safety and emergency directors. And we're just going to talk a little bit about how we have been handling our behavioral health patients in our ED the last couple of years. We are in Linton, Indiana, which is southwest Indiana. Brian will be giving the majority of the presentation, so I'm going to go ahead and let him start.
Good morning. We began a couple of years ago where our hospital board and administrative staff come together and decided that safety was an issue and a priority to them. They reached out and started hiring a new security staff. The security that they had before was only on night shift, like a lot of hospitals, only on nights and then sometimes only on the weekends. There was no 24/7 coverage. They were not law enforcement. They had no law enforcement authority. And then whenever they hired the new security staff, we are all members of local law enforcement. We're either active, have retired from active duty and working as reserve officers, or sworn in as special deputies from an outside agency surrounding areas that have full arrest authorities. That's pretty much the background of the security program. Is, you know, we started it in early 2014, I believe, and we've been working on it since then. The communication with our local law enforcement, again, we are all local law enforcement. We're all sworn officers. We've all worked together in the past on the streets with our citizens and with each other. We see a lot of the same people that we deal with outside this facility and also inside the facility. Beginning whenever we first started our progress here, we would have drug seekers. You would see them come in the foyer and through the first breezeway door, see us sitting there at the registration desk in uniform. They'd just turn around and walk back out. We had several of those, and we knew them, most of them by name, because we'd either dealt with them the weekend before or the night before. That's pretty much the communications. Also, whenever I first began, I actually went around and met with the sheriff, all of the local police chiefs, the town marshals, and told them what our issues or our concerns were and talked to them and seen what their concerns were and what their issues were. And we've tried to work together since then to get their officers back out onto the streets and not stuck in the EDs for 3, 4, 5, 6 hours at a time, if at all possible. We also do annual trainings with them. Their communication packets that I believe most critical access hospitals send out or should send out to their law enforcement. We talk about those. We send those out on a regular basis and update those with our policies. We do quarterly training with our local law enforcement in the county. And again, since we are local law enforcement, we have a day-to-day operation where we deal with all these other departments and see these other officers on a regular basis. Beginning back with our administration and our board of directors, the importance of feeling safe at work, that was a concern, not only, the nursing staff, but all the ancillary departments, registration, they're at the front line. They're sitting right there at the door. X-ray, lab, housekeeping, everybody involved had shared concerns with the issues. So what I've gotten so far is that they're happy to see us. We've been working together for some time now. Whenever we do our rounding, our watch tours throughout the hospital, we stop and talk to these people, stop and talk to the staff. And they have questions, they have concerns, not only inside the facility, but also outside in the public, what's going on. So that works well. And they've shared with us how much better and how much safer they feel at work. As we all know, this workplace violence has become a big issue in the last year. It's been a real big push. We were tasked with coming up with a workplace violence program. We've done that pretty well. NIOSH, National Institute of Occupational Safety, defines workplace violence as any physical assault, threatening behavior, verbal abuse occurring in a work setting. Then you have your World Health Organization that actually goes a step further and talks about even commuting to and from work, if it has to do with your day-to-day work criteria, that it also falls under that workplace violence. We actually we've met with all the different departments throughout the hospital, myself, our risk management gentleman, and then Jill also on our director of quality. We met with each of the departments within the hospital, even with our board of directors, our administration, and went over our workplace violence and program and our policies we've dealt with. Another big issue that we've pushed on is that right response de-escalation program. Right response is put together through a company called Service Alternatives. I've taken some other forms of like CPI and then the right response. And the de-escalation, I think, program here in this hospital works because we've got our administration and board of directors on staff. Our administration, they've all taken this course. It's mandatory for employees, admin, all the way to our ancillary departments. We've done housekeeping, dietary, social services. They've all had this training and continue to do the training. It works because it's done by the coworkers that they deal with. It's not somebody from psych services that comes in that you never see or never deal with. It's one of their own persons or coworkers that has come in and gives the class, and makes it a little easier to understand when we have real life examples that we can present to them. It goes over and has been well received, I believe. Some advantages that we've had: officer presence has decreased behavioral issues, behavioral situations. Again, our rounding that we do, our watch tours throughout the hospital, our staff, we're out at least an hour every 2 hours, walking the halls, checking with the nursing staff, see what's going on, if there's any concerns, checking with the doctors, and also all the ancillary departments if they have any concerns that has decreased our behavioral issues. Again, if we have an issue, we have an officer that's there in uniform that we deal with. We deal with the situation when it arises. We've had good working relationships with our nursing staff. Most times when people deal with police or security, they don't deal with them on a day-to-day basis. It's always in the bad times when you have an issue, you call for help. It's not on a day-to-day basis where you actually get to see somebody in a different light as a person and not just the officer that comes to take your complaint. Emergency detentions, they've been going quicker. They're always going to have problems just because of that's the nature. You know, we have problems with placements. It's never a good thing, but because we have the one-on-one contact with our judges and our court staff, we deal with these emergency detentions on a regular basis. How to fill out the paperwork, where to take people. It usually, I believe it's gone smoother and quicker, especially the after-hour contacts with our judges. We know them. We deal with them on a weekly basis on the outside, so that has always been better. Overall, our hospital staff feels safer. They stop us on a weekly basis, and the other staff, the other public safety officers, and express their appreciation to have us here and to just be able to just converse with us. And I think it's a win-win situation with that. You'll see our numbers here. This is in 2015 when we started our monitoring here. Our numbers have went down. Our ED patients requiring public safety, where they've gotten out of hand, they've been disruptive. Nursing staff doesn't feel that they can handle it and they want to call us in. Went from 150 in 2015 down to, in 2017, we're just over 70 now since this has been put together. But we're still on track to be half in the last 2 years. Our ED patients restrained due to combative behavior has went down considerably. Again, you know, we deal with these people. They know us. We deal with them on the street. We deal with them here. It's went down from 15 in 2015 to 7 so far in 2017.
So as a male staff member, this is Troy Gaither. I'm the director of the ED. I've been a nurse here for several years, but as a staff member, before we had Brian and his security team on board, basically the male staff members were the ones responding to these behavioral problems with patients. And it would be a weekly incident where there would be some sort of violence episode with somebody coming in or dissatisfied, not getting their pain medication, that the nursing staff would have to deal with, or maintenance staff would have to be called to help with those patients. Since implementing the law enforcement and Brian's security staff, nurses feel much safer. They don't have to deal with that. We don't have near the problems with the patients that we used to have as far as the acting out and the violence. So really, I think all the improvements have came from developing this program, going away from having those, we had some geriatric retired people doing security checks. They would walk around doing just time clock checks, the rounding. Actually, we now have security force, and it's made a huge difference in the patient's responses. We don't have to deal with the issues that we have in the past. One thing that we've developed in the last couple of years also is we started working with the behavioral health patients. with Hamilton Center and Bloomington Meadows. So we have things set up with Hamilton Center. Actually is right across the street from us. We have a local branch. If there's a need for a face-to-face, and it's during office hours, they can come over and they will actually do the face-to-face in our ED. If they don't have the staffing or if it's after hours, we do have tele-mental health services set up with both Hamilton and Meadows hospitals. So we have 24/7 behavioral health consults. It is still difficult to get those patients placed, but Hamilton Center does actually help Meadows as well. Both actually help place those patients. If they don't have the capacity for those patients, they will help us actually find placement for those patients. So that's been a big help with us. What should we have done differently? Basically, the only thing I can think of that we should have done differently is started this several years ago before we actually did. I can't say enough about the change in the feeling nursing staff secure and safe. The patients are getting better care. Our restraints have decreased. The amount of violent outbreaks in the ED and throughout the hospital have decreased tremendously. So basically just getting this program going earlier would be the only thing I could think of that we should have done differently.
And Becky, that's what we have.
Okay, well, thank you very much. I did have one question chatted in, wondering how often you repeat the de-escalation program.
The de-escalation program, we do a monthly training session, at least once a month, but we are required by their service alternatives, it's on a 2-year renewal. So every 2 years, the individuals or the staff is supposed to go through and do a refresher course.
Okay, thank you. I'm not seeing any additional questions in chat right now, but if any others come up, why? There just was one question that came in is, how do you financially support this program and how big is your facility?
The financial part is just the board has agreed to fund it. There was no grants. It was just a expenditure that they've set out to determine that it's worth the cost, satisfaction rates, and employees here at the hospital.
We're a 25-bed critical access hospital.
Okay, thank you. Any additional questions? Okay, well, thank you very much, Greene County. Really appreciate you sharing your information.
Thank you.
Next, we have on the agenda Jen Peterson from First Light Health System. Jen, if you'd like to share your screen with your presentation, I will turn the floor over to you. And we can see your slide presentation now. Jen, are you muted? We might need to unmute everyone. Jackie?
Yes, I have.
Can you hear me now?
Everyone. Here we go.
Jen,
Hi there.
is this Jen?
Yep, this is Jen. Good morning.
Good morning. We can hear you now.
Good. How is everyone this morning?
Good.
Good. So I will try to start my slideshow here. I can get it to click. Good morning. I think I'll be speaking about this project a little more from a community perspective. We were chosen to be a part of this IBH grant with, I believe, 5 other hospitals in Minnesota. And when we started, we were able to do a work day with the project that helped us identify how we could make the best impact. And out of that work day, we found what we wanted to work on was population from ages 18 to 64 with co-occurring mental health and chronic disease. We wanted to look at both our primary patients and our patients who came to us who did not have a primary with us. And then one of our main focus was to build relationships with our other community mental health providers. We started with, I guess, statistics were our the first place that we started to figure out what it was that we were really dealing with. And we found in our first quarter of statistics that we had about 144 visits to our emergency room with a primary behavioral health or substance use focus. So out of about 900-ish visits, so it was about 4% of our population. However, the time that it takes us to place patients, to create good discharge plans, and to have actual follow-through was really taking a lot of our staff time. And that is due to a number of factors, but we really wanted to try to focus on what we could. So we tried to identify as many agencies, providers, and other supports that work with our patients who have mental health concerns. We serve a 5-county area, so about 26, it's just an area that has a lot of isolated rural patients. So there was a lot of people to try to invite, and we probably missed some, but we ended up with a group of about 10 agencies. So our schools, our sheriff, our local social services in our Kanabec County, Child Protection was there, our mobile crisis response, which plays a huge role in any of the discharges that we have. Hold on one second.
Yeah, and that's all he needs. That's all she needs.
So we had probation officers, we had any of the outpatient therapy providers that service this area, and then the resource coordinator for the mental health in our region, which is a 5-county region. And then within First Light, we had many from our social work department, our psychiatric nurse, and then 2 outpatient chemical dependency providers also came to that first meeting. We discovered that a lot of us struggle with the same issues in mental health, and I would say one of the things that we really identified was that mental health care coordination is about, I would say, about a decade behind chronic care coordination. I just think that we haven't removed those silos. We haven't met together. We haven't all gotten at the same table and said, what kind of issues are you facing and how can we help and how are we connected to each other for our patients? And in the world of chronic disease management, that seemed to have started about at least 7 years ago, where we were sitting down with our nursing homes, our home care providers, and trying to figure out the best ways to get rid of redundancies and communication issues. So when we sat down with these community providers, we found that a lot of us are having the same challenges: access, triage, and referral bottlenecks, limited education for our community, limited knowledge of what services are even provided, and then patient engagement always being a challenge. If you're not getting the word out about your services or you're not reaching the right places, how are you getting patients engaged in better mental health care or earlier mental health care or any mental health care? So those were areas we found that needed a lot of work. Just general information sharing about what each of our agencies actually provide and what we do. There was many innovative programs and resources sitting out there that many of us are not accessing on a very regular basis. Of course, there's always a lack of acute inpatient and crisis beds. I think I can't imagine that that's any different in anybody else's state. But in Minnesota being a more progressive state, we still really struggle with this issue. So those are kind of the things we sat down and said, hey, we're all in this together. How can we, what are we going to do to approach these issues? What we decided was that just getting together in the same room is probably one of the most valuable things we can do. Above and beyond that, we obviously want to have some tasks that we leave with, some projects that we're working on. But so we broke into two groups, one that is working on providing community education, one and improving care transitions. We wanted to coordinate care and then make sure we're applying best practices. If one of our agencies is doing something cool or amazing, we really want to share that learning. Sorry.
Okay, okay, thanks. Yeah, bye-bye.
So this slide is way wrong. I think we've probably had 6 successful and growing community meetings. We begin with just a time where we go around and talk about what's new at our agencies, and just that learning has been amazing. I think that working in our silos, we're all working so hard in our areas to get all these programs and provide these services, and then forgetting to sort of tell each other, including each other in our plans, or communicate how you get into these programs or how we can help you.
We are not seeing your slides. Are you pushing through on those?
Oh, did it just stop?
No, we're just seeing the very first slide that says First Light Health System.
Oh no.
If you want me, I can go ahead and pull it up and share my screen, and I can go ahead and do it for you if you're having trouble.
I'm sorry, I didn't know it says that I'm sharing my screen.
Yes, we do see the first one, the first slide, but just not the other ones.
Let me try something else real quick. How about now? What do you see now?
It's still the your first slide, the First Light logo. Yep.
No, we didn't hear that up here.
Maybe, okay, then maybe we should.
Yes, that is fine. Let me go ahead and share my screen. So I will go ahead and do your presentation, like flip through it.
Oh my goodness, I'm so sorry.
No, that's fine.
I was rambling on and I didn't realize you were not seeing me.
Let's see. I'm just trying to find your presentation on here. Let's see.
Just get to the room, turn around, they don't know what I'm going to do.
I wish I could figure out why it's not advancing the slides for you guys.
Okay, can everybody see this now?
Like this street that that I have up here, I think it's just this group, they just don't answer.
Okay, I'm not sure what slide you are on. Do you happen to know off the top of your head? Keep going.
Yeah, keep going. I think I'm on the subgroup side.
Oh, that's all.
Keep going. There we are. This one.
One back?
One back.
There you go.
Yep. Actually, one more back. There we go.
Okay.
So, so we continue to meet we have 3 groups that meet. We have the entire large group. We come together every other month. And then in the month that we don't meet, there's 2 subgroups. There's the outpatient no-show and engagement group. And that is the group of outpatient therapy providers who are working through no-shows, patient engagement, and attrition. So that group has been very active, just trying to figure out how to work together to get referrals going. They made this really amazing outpatient resource for our primary physicians to give to patients when they're trying to choose a therapist. So listing out the insurances that each therapy provider takes, the like their general focus of therapy, and then a little like brief bio on each therapist that they have, as well as programming that they offer. Because I think for people who have not been in the world of mental health, those things are all very foreign. No, they don't know what a DBT group is or why it exists or what is day treatment. So our primary physicians and their nurses have been educated on how to provide a warm referral. And they think it's helping their attrition. And then the community education and awareness group they've done a couple community activities that have been well received. And they are considering joining together with our local, very well-established substance abuse coalition. So I think that between substance abuse and mental health community education, they're really going to take off right now. So we're looking forward to that. Within the larger group, there's just a general sense that our community has really been underprepared for the challenge of mental health, and especially in the public health sort of education sector. So we've done some work around that. And everyone remains excited. The project is over with the Rural Health Network. We continue to do some calls and some education with them. They've started another cohort behind us doing similar work, but we will continue to gain collaboration and education through that group. But this group that we've formed has not lost interest or steam, and we're at about 1.5 years right now. So it continues to evolve. The larger group meeting really seems to be that everyone likes to get in the same room and let everyone know what's going on in their agencies, as well as talk about some pertinent judicial, like legislative things that are going on in the state and how we're all connected in the region. So that's been really informative and helpful. And I just think a lot of us are just sort of marveling at how we didn't do this sooner, and what a big difference it makes to just know what everyone else is at least attempting. I think one of the big learnings that we had was that for a long time in smaller communities, we just talked about needing more beds and, you know, the state needing to help us fix this mental health problem, and really realizing that it was on us. It's on our communities. We need to be better. We really need to decide that it is that we can fix, or we can at least attempt to make mental health services better for our consumers. And a lot of what we found is you have to gather data, and you have to not just feel that there's a problem, but you really have to measure the challenges and have new approaches. And one of the big things that at First Light we're doing is following along in our care coordination, chronic care management programming is mental health case management or care coordination, really. So that's kind of our next big, we're kind of sitting on the edge of mental health care coordination and doing some strategic development of programming, deciding what will be our focus, how will we serve this community from our primary clinics, how will we be addressing mental health in the next 20 years? Because it's not something that can just be addressed somewhere else. We really know that we have to be collaborative with other providers and service our patients. So that's probably some of the best stuff we've learned. You can advance the slide. I think it's my last one. So we started measuring. We are measuring the number of primary visits, total spending on those visits. In the clinic side, we're looking at decreasing our PHQ-9 scores at our 6-month clinic follow-ups. We have a psych nurse NP who's hot on that statistical data and how to improve it. I just saw her put out an email to all clinic staff about making sure that adults are getting there if they're having a positive PHQ-2. And I don't know if you're familiar with PHQ-2s, but it's a screening tool for depression, that they are then having to follow up PHQ-9 at that visit and then again in 2 and 6 months. That's been her project, and it's really shown improvement. Another thing we're looking at doing is offering some depression support groups, smaller groups, people who have a moderate to severe depression but don't have other services involved, people who generally can fall through the cracks of even like SPMI or chronic mental health care, and maybe have no prior education or awareness of what it means to have a new diagnosis of depression. So some of those groups will be utilizing our clinical social workers in the clinic, not necessarily in therapy practice, but in small groups and consultant types of roles. We also are just continuing to look at the number of ED visits for our first light primary patients, which end up being about 40% of our mental health visits. The other 60% do not have a primary in our system and most likely do not have a primary anywhere. So how to offer those services through primary care to those who are episodic or come in an emergency, really getting them wrapped around with care that continues after they leave and when they come back. I think that is one of the things that we can really do to serve our community better. You can do the last slide. I think it's the last slide.
It looks like that is the last slide.
Is there not one more? I think we had. Okay.
Not letting me advance, so I'm guessing that is the last slide.
Okay. Okay. I think I have a wrap-up slide, but it basically says that we have learned a lot through this collaboration. We've learned that we need to collaborate, that being siloed in mental health care is a huge part of our challenge, that our consumers deserve more, that the state is not going to fix our challenges with more beds, that really community mental health care is one of the places that we can really move the needle on better care for our patients, and that community education and awareness and outreach is a huge part of that, and that we really have to work together to reach these goals. So we're very thankful for the Flex Grant and working with the Rural Health Network. They've brought us 1 million best practices, and we're just looking forward to using them all. Oh yeah, there it is. Yeah, network. Yeah, there we go. Our general findings were that networking is beyond valuable, that the use of multiple diagnosis codes make data collection difficult. Hopefully our electronic medical record is about to solve some of this for us. We were underutilizing our mobile crisis team, that data equals solutions, and that using our care team model for chronic disease management can be used with our behavioral health patients as well. And that our community resources are really, there are a lot more than we recognize, and getting them all connected will benefit our patients and our community.
They are all with patients. I can definitely.
So it seems like simple things, but it was eye-opening, and we're ready.
Yes.
For solutions instead of the common feeling that it was just an overwhelming problem that we weren't going to be able to solve, that we didn't have any hand in, that we were waiting for someone else to fix. And I think it's really made us more engaged in believing that we had some of the tools we needed to make it better. And that's it.
Thank you very much. Becky, do we have any questions rolling in? Oh my God. Let me go ahead and unmute you, Becky.
Can you hear me now?
Yes, we can hear you.
Okay. Thank you. Jen, thank you very much. Right now, we don't have any questions in the queue, but many times after a presentation, I'll receive some. And if there are, well, I'll forward to you, Jen, and then distribute to the group. So thank you very much. It sounds like you've done a wonderful job in your community. Okay. At this time, then, we'll move along in our agenda. So if you will stop sharing your screen, and then we'll move on to Janae Myers. And Janae, if you'll share your screen. Janae's going to be sharing information on antibiotic stewardship and some resources that are available in Indiana. There's been a lot of hard work that's taken place, and we want to make sure that everyone is aware. So Janae, I'll turn it over to you.
All right, thank you, Becky. Can everyone hear me?
Yes, we can hear you.
And
all right, and let's test the slide advancing capabilities.
It is working. You're good.
Okay, great. Okay, great. Thank you for inviting me to present. I'm very honored. Today, we're just going to talk a little bit about antimicrobial stewardship in critical access hospitals. I have some Indiana-specific core elements data. I'm sure that you've all probably seen the implementation guide for the core elements specific to critical access hospitals, and I have a few specific examples of implementation strategies. So what is antibiotic stewardship? It's a set of commitments and activities designed to optimize the treatment of infections while reducing the adverse events associated with antibiotic use. And if you say this to someone on the street and they ask you, what you do, and you give them this description, they kind of look at you like, what? So basically, it's just a really complicated way of saying the antibiotic stewardship programs help ensure that patients get the right antibiotics at the right time for the right duration. So the CDC released these 7 core elements for hospitals in 2014, and those elements are leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. These core elements are all housed in the Joint Commission new antimicrobial stewardship standard that became effective January 1st, 2017. And specifically, these are all in the 5th element. So if you've ever taken a look at that and gone, oh my gosh, what is going on in element 5? It's just the core elements. So are we meeting those elements? Kind of. The CDC tracks how many hospitals are meeting the core elements. They use the annual hospital survey in the NHSN module. In 2015, they found that 50% of hospitals with greater than 50 beds met all 7 elements. However, only 26% of hospitals with 25 or fewer beds met all 7. I took a look at our Indiana data, and those data show that in 2015, 59.1% of our hospitals with greater than 50 beds met all 7. However, only 34% of our 25 or fewer bed hospitals met all 7. So the 2016 data does show improvement with 82% of our hospitals with greater than 50 beds meeting all core elements and 58.8% of our critical access hospitals meeting all 7. So like I said, there was a lot of improvement, which is great. I mean, especially in just 1 year, we really showed a lot. However, you can still see there's a pretty big disparity between our critical access hospitals and their larger counterparts. So this kind of just shows that the resources that are being provided are not meeting those particular needs of the small facilities. So earlier this year, the CDC released the implementation guide for antibiotic stewardship core elements at small and critical access hospitals. And what happened was the CDC and its partners met with hospital representatives to get their feedback and kind of get a better understanding of the challenges and develop resources that are uniquely tailored to this setting and the patients that you all are serving. So the CDC did partner with the Pew Charitable Trust, the American Hospital Association, and the Federal Office of Rural Health Policy to develop this resource. And, it's just an effort to improve antibiotic prescribing and use and to protect our patients. So really, at the end of the day, that's what we're trying to do. So I'm just going to go through a few pointers from the guide and just kind of synthesize the information. I've combined some of the leadership or some of the elements for sake of time and just to make things maybe a little bit simpler and maybe a little less overwhelming. So I put the first 3 core elements together: leadership commitment, accountability, and drug expertise. So the first 2 boxes are things that can be done in the facility, and as you can see, the 3rd box is kind of some off-site support that your facility could
kind of engage in. So appointing a pharmacist leader, ideally someone who is on site, either full or part-time, considering having stewardship as part of the job description or the service contract of pharmacy leader, designating a physician in the C-suite to be accountable for stewardship program outcomes. Supporting training for hospital stewardship leaders is huge, you know, especially in the critical access hospitals where maybe people are wearing a lot of hats. Getting that specific training is very, very helpful. They do really like to see pharmacy and physician co-leaders. Not only are you getting their infectious disease, hopefully expertise, but also having that pharmacist at the table also really helps with that drug expertise. Some other things that you can do in your facility are creating a reporting structure for the stewardship program and just making sure that the information is actually getting back to your facility leadership. You know, they're gonna wanna see that the program is successful, and the more that you can get that in front of them, the more success that they, and the more leadership commitment that they're going to provide, and it's kind of this wonderful, hopefully, cycle. Having that formal board-approved statement on the importance of antibiotic stewardship is wonderful. Maybe a little bit hard to get, but it just is so helpful because then, you know, you're able to hold that up and get more buy-in. You know, leadership supports this. You know, we need to work as a team to help this. Enrolling in a collaborative, so the State Hospital Association and quality improvement agencies, I know that our QIO here in Indiana does have some stewardship collaboratives. Funding remote consultation with stewardship experts, so pharmacy and physicians, if they're not available or really not that accessible in your facility, and incorporating stewardship requirements into contractual responsibilities of external pharmacy services. So if that's something that your facility has, maybe building that into the contract, and then you're able to have that service. Number 4 is action. It's probably one of the bigger elements. These are a few things that you can do in your facility that would be action. Having the antibiotic timeout, we'll touch a little bit on antibiograms, nurse-driven stewardship, and additional opportunities to improve antibiotic use. I cannot stress this enough. Avoid implementing too many policies and interventions at the same time. So that's a really, really good way to get initiative fatigue, and then nobody will pay attention. So always prioritize your interventions based on the needs of your facility. And this can be defined by your measures of overall use and other tracking and reporting metrics. So taking a look at where your facility is and maybe picking one intervention that's maybe a little bit lower hanging, and that will get you started before you start rolling out some of these bigger ones. But the first one is the antibiotic timeout. So as we know, antibiotics, they're often started empirically. We're obtaining that diagnostic information. However, a lot of times we're finding that providers don't necessarily revisit the selection of the antibiotic after we get that laboratory data. So this antibiotic timeout, you know, 48 to 72 hours after the culture result is ordered and you have that back, you kind of prompt a reassessment of the continuing need and the choice of antibiotics. And you should really kind of have a process in place, like I said, you know, 2 to 3 days, whenever you usually get the results back. And basically you're asking, you know, does this patient have an infection that even needs antibiotics? Are they on the right one? Can we de-escalate? How long should the patient receive the antibiotics? And just kind of taking a look at, is this a place where we can safely cut antibiotic use because the patient does not need this? I hear a lot about antibiograms, and I get a lot of questions about those from the nursing homes, but also a few critical access hospitals. An antibiogram is any lab report with susceptibility results, but the one that you're probably hearing or asking the most about is actually a cumulative antibiogram. So the terms are kind of used interchangeably, but the cumulative refers to all of your data from 1 year. So basically what happens is that your microbiology, and usually there's a pharmacist involved, they pull the susceptibility results, and then they list the percentage of isolates susceptible to a variety of antimicrobials in a given time period, and that's usually 1 year. It's also called an antimicrobial susceptibility pattern. Some of the issues with this especially in the smaller facilities, are that in order to have a statistically significant antibiogram, you need at least 30 isolates per each organism, and that's kind of difficult to obtain. So one thing that you can do is maybe take that out farther than 1 year and kind of put in the caveat of this is a couple years of data, or I do know of people who have kind of maybe worked with other facilities in the area and kind of put one together that way. It's really, it's a bit of a double-edged sword. And I could do a whole presentation on antibiograms, and I have. But, you know, it is an option out there, and, you know, I would be more than happy to chat with you about maybe what your best option would be, but that's another option. Yeah, so moving on. Earlier in July as well, the American Nurses Association worked together with the CDC, and they were exploring how nurses can become more engaged and take that leadership role to enhance antibiotic stewardship efforts. And I harp on this all the time, I cannot stress enough how important nurses are in antibiotic stewardship, because these are your frontline workers. These are the people who are very familiar with the patient. So they know if when the physician comes in and evaluates the patient, they know if the patient is having a good 15 minutes or maybe a really bad 15 minutes. So they know what is normal for the patient, and they can kind of advocate for the patient. So on this slide are a few recommendations of ways that you can involve nurses in your stewardship programs. There's a webinar, I think December 4th, that is going to go more in depth into this, but they're just very, very valuable. And especially if your facility doesn't have a whole lot of resources, just getting your nurses involved in stewardship is awesome. And the research, and from what I have heard at just from nurses themselves and at conferences, is that nurses want to be involved. You know, they're there to care for the patient, and they want to help the patient get better and go home. So they are a very valuable resource that clearly I cannot think and talk highly enough of. So this is straight from that critical access guidance, and this is just key opportunities to improve antibiotic use. We won't go through it, and it is, again, in the document, but the main point that I want to stress about this table is using criteria to establish diagnoses. So this is going to help you avoid prescribing antibiotics for illnesses that are not infections. A huge one is asymptomatic bacteriuria. Also really important to highlight is the discharge prescription. So make sure that whenever you're discharging a patient with an antibiotic prescription, whoever is prescribing and putting that order in considers that the antibiotic therapy treatment that they have already had in the facility should be incorporated into the duration of therapy. So if they have a condition that, you know, have about 7 days of treatment, and the patient has already been treated for that in the hospital for 3 days, they really only have 4 days of therapy remaining. However, whenever the order goes in, some of the electronic systems will automatically populate that 7 days. So that's another thing to kind of be aware of, depending on, you know, how your system works, is making sure that duration of therapy that they're being discharged with does incorporate any treatment that they have already received for that condition in the facility. So elements 5 and 6 are tracking and reporting. Days of therapy are considered the most useful measure of antibiotic use. So antibiotic expenditures don't always correlate with your antibiotic usage, so using them to track the effectiveness of stewardship, it's not really a good idea, because it's not accurate. A lot of facilities are going towards the NHSN antimicrobial use and antimicrobial resistance module. That's really difficult. I mean, a lot of our larger facilities here in Indiana they are not able yet to even be opting into that. So, you know, it could be a long ways off for even them. So the CDC does recommend that you calculate the defined daily dose using those World Health Organization guidelines. I have them linked on the slide right there. Also really important is monitoring your facility adherence to the guidelines. So it's really, really great to track things. tracking things is wonderful, but then you have to report on them. You have to make sure that you're actually doing something with those data, the stuff that you're tracking. Are your interventions, are those effective? So whatever you're reporting on should obviously be consistent with your action and your tracking. So, if you want to monitor your meropenem usage, you should be reporting, okay, well, it's great that our meropenem usage went down, but look at what we went to instead. Our clindamycin usage has increased. And now we're looking at our C. diff cases, and now our C. diff has gone up. So be consistent and report on what you're tracking. And also make sure that you're reporting those to the providers and the key stakeholders. So one way to really get that leadership buy-in is to say, hey, look, we are tracking our interventions and we're reporting back to you that they are successful or they're not successful. So we need to try something else and we need your support. So make sure that you are reporting and you're including everyone who should be included. And finally, education. So the Joint Commission, effective October 1st, they did delete that medication management standard, MM090101, element of performance 3, from the hospital and the critical access hospital programs. And this removes the requirement that hospitals and critical access hospitals must educate the patients and the families as needed regarding the appropriate use of antimicrobials. So basically, the Joint Commission got a lot of feedback that patients are too ill to receive and retain that information, and also that facilities had enough on their plate with just educating their own staff. So they have removed that element of performance. So some of the basic educational things that you can provide are messaging to your staff through posters, flyers, newsletters, and electronic communication. And again, making sure that that is getting back to your leadership and your other key stakeholders. More maybe intermediate things are the didactic presentations. Those can be formal or informal, incorporating your stewardship education into credentialing or re-credentialing education. And some of the more advanced are to, reviewing de-identified cases with providers. And this will help evaluate their practices as well as, hey, what if this case walks in the door again, what can we do to improve patient care? And those are some additional resources. They are all linked on the slides. And there's my contact information. Does anyone have any questions? I kind of went through that pretty fast to be mindful of everyone's time. So I can take your questions or they can email them to me afterwards.
Janae?
Yep.
This is Becky. Just wanted to point out that in the chat feature to everyone that there is an Empowering Nurses to Protect Themselves and Patients, the Nurses Role in Antibiotic Stewardship program that will be December 5th from 12 to 1, and the registration link is there as well. And Janae, if individuals want to share any of the tools that they have developed, is there some place or a contact person that they would could send those resources to share in addition to forwarding them to me?
They can send the resources to me. I have a listserv of as many infection preventionists as I can get in the state. I don't think it's entirely comprehensive, but there are like 200 people on the list. So if they're willing to share those with that many people, I'm more than happy to share those out throughout the state as well. And I can also put them on our Indiana State Department of Health antibiotic stewardship page. It has information for critical access hospitals, general acute care facilities, outpatient, and long-term care facilities. So I can put those up there as well. Great,
thank you. So there's several resources of the State Department of Health, the Hospital Association. Q-Source is very focused on the outpatient area, and then if you're needing assistance, you can also reach out to me at Valiant Health. This is Becky. And for the sake of time today, and I apologize for the issues that there have been with the Zoom system today, I'm going to pass off the presentation to Karen and Abby. I will send out an email with updates that I had. The only slide in particular I want to make sure and point out, and all of the slides were distributed prior to the call, was the Emergency Department Transfer Communication Technical Expert Panel. It's slide 16 on my presentation. But Stratus Health is facilitating a technical expert panel to review the Emergency Department Transfer Communication measures, and then recommendations from that technical expert panel will be used to inform potential update to the measure structure and/or measure specifications, and then those recommendations will be submitted to the National Quality Forum. So again, they're seeking some input all across the nation, and there's a 4-question questionnaire that will need to be completed by December the 15th, and I will be sending out the link to that questionnaire. So, okay. So at this time then, I will turn the presentation over to the State Office of Rural Health presentation related to SHIP. So we have Abigail Garcia from the State Office of Rural Health, as well as Karen Kennedy from the Hospital Association. So Abby, I will turn it over to you at this time. So if we can make sure that Abby is unmuted, that would be wonderful.
Yes, Abby is unmuted.
Can you all hear me?
Yes, we can hear you.
Okay, thanks so much, Becky. I just wanted to give a quick introduction. Through the State Office of Rural Health, we get the SHIP grant, and that traditionally has gone through the State Office of Rural Health to rural hospitals. And we are going to talk today about, first, Karen is going to do a presentation on a carryover project that we sent out a survey about a few months ago. And then I'm going to talk about how we are transitioning the SHIP program overall. And so I just wanted to introduce Karen and let you all know that we're going to talk about SHIP going forward and what she's got planned for a carryover project that will happen between February 1st of 2018 and May 31st of 2018. So Karen, you can go right ahead. I don't think Karen's unmuted.
I'm going to go ahead and unmute all so I can figure out which one Karen is on.
Hi, good afternoon, everyone, and thank you for having us today. The Indiana Hospital Association is very excited to partner with the Office of Rural Health on this carryover project. When we were approached by the Office of Rural Health, initially IHA did some research. In particular, we were interested in learning more about what other states were doing and what kind of SHIP projects other states were engaging with their rural and critical access hospitals. Throughout that research, we found several projects, but one of them that piqued our interest was a project that has been done in Kentucky, and it focused on ICD coding reviews and education with best practice recommendations for small rural hospitals. And what was great about this project, as we learned more about it, is that it was done in partnership with Blue & Company. And Blue & Company has a long history with the Indiana Hospital Association, and actually our offices are right next to each other. And what we found is that there was staff in the Indianapolis office that helped coordinate this project in Kentucky. So it seemed like a great win-win. So we proposed the project to the Office of Rural Health, and as a result, we're moving forward with this project, as Abby had mentioned, as a carryover project to the SHIP program. And she mentioned it will begin in February 1st, and it will run through May of 2018. So, you know, Blue & Company, if you're not familiar with Blue & Company, historically it's an accounting firm. They have experienced HEMA credentialed trainers that have a lot of expertise in ICD techniques for improvement in coding, productivity, quality reporting, and financial performance. So at this time, I'm going to turn it over. And Becky, I'm actually not able to advance my slides.
I'll go ahead and pull them up and share my screen. Does that work for
Okay.
you? Okay.
Yes, that would be perfect. Thank you so much.
You are welcome.
So this time I'm going to turn it over to Lynette Tom. Lynette is with Blue & Company, and I might also point out that she is the president of IHEMA, or the president-elect of IHEMA. And so we're really thrilled to have Lynette partnering with us, as well as some others at Blue. So at this time, she's going to give a high-level overview of the coding project. The Office of Rural Health did send out an initial interest out to all the hospitals, and so there is approximately about, I think, 15, 17 hospitals that did indicate that they are interested in participating in this project, and we will be continuing to do some recruitment on that. So if you didn't complete that survey and send it back, there'll be some follow-up activities that you can go ahead and do with that. So at this time, I'm going to turn it over to Lynette. And actually, Jackie, I see there's actually different slide deck.
Okay. This is the ones that I received.
Yep.
So is it just the wrong presentation in general, or is it wrong slide?
There should be the slides that have the IHA. It's titled Final Small Rural Improvement
Okay. I have those up as well. Can you all see that now?
Yes,
okay.
Thank you. And then, so we're on the second slide now.
Let's see. This one?
There, perfect. Yes.
Okay, great. Thank you all for having me. Again, my name is Lynette Tome, and as Karen mentioned, I am the president-elect of the Indiana Health Information Management Association. And with that opportunity, I get to advocate, educate, and work with the HIM professionals across the state and sometimes across the country on matters that influence its members. 60% of our members are coders, so I'm pretty familiar with a lot of the coding staff here in the country, or excuse me, the state. So in addition to that role, I've been with Blue as a senior consultant, and I have experience in implementing ICD-10, and our continued work at Blue in this area has proven helpful in understanding the multiple changes that ICD-10 has brought, and not just at its implementation, but as we have advanced through the years of ICD-10, many changes have come about that kind of have reversed earlier guidance. So we thought it was important to help hospitals understand that ICD-10 coding is vital to data reporting in today's healthcare industry. We're excited to offer this project and feel it will provide an excellent tool for rural hospitals in identifying baseline performance indicators, or KPIs, and an action plan that can be used to improve performance in key areas such as coding and clinical documentation improvement, which is also known as CDI. So ICD-10 is far more far-reaching, whether your hospital is critical access or PPS. Correct coding impacts reimbursement from Medicare and other payers. It also affects coverage and medical necessity for services, of procedures, supplies, and drugs, as well as prior authorization requests. ICD-10 coding is a key driver in value-based purchasing, in bundled payment initiatives, and in the shared savings and ACO programs, making it critical for hospitals to have success in painting the clinical picture of the patient's encounter. So we encourage eligible hospitals to respond to the request for participation in the SHIP grant project. We feel that the project will be beneficial to all, and greater hospital involvement will allow us to provide more robust data analytics. From participants, we'll be seeking volunteers for a coding and documentation review of inpatient and outpatient records. Our goal is to seek a solid cross-section of records from rural hospitals to study. This part of the project will entail an on-site review of some records, while other records will be analyzed off-site at our office. The other aspect of the project includes an online survey to all participating hospitals that will assess certain coding and clinical documentation or other KPIs related to ICD-10 coding. Respondents will supply anonymous answers, and then we will analyze the survey responses and report the findings on a dashboard. You can go ahead and advance to the next slide.
For some reason, Zoom is just not my friend today. It's not letting me advance to the next slide. Let me see.
Okay. I can briefly just go ahead and start talking about it.
There we go.
So perfect. Okay, so the last piece of this is we will de-identify the results of the coding review, combine the results with the survey answers, and we will use that information to construct our training education. This last phase of the project will include 2 opportunities for shared learning. So the first will be a live presentation that's designed for the HIM department managers, coders, CDI staff, or any others working with this information. We also encourage quality staff, quality nurses, and other staff. And this will be recorded for those that are unable to attend the live session. This training will entail an in-depth coding education related to the audit and survey. And the presentation will also allow for CEU, or continuing education units for AHIMA credentialed coders or other staff. Then a second, more high-level overview of the findings with best practices designed for mid and upper level staff and executives will also be provided in a webinar, and that will also be recorded. Finally, all hospitals in the coding audit pool will receive their individual coding analysis in addition to the webinar shared learning activities. So we encourage hospitals to consider participating in this project, which we feel will offer great value to small rural hospitals while ensuring the SHIP investment activity requirements are met. And then if we can get to that last slide there, Scott Trida is the director over my department, and my information and Scott's information is on that slide there. And for your reference, and we're available for questions as necessary throughout the process in conjunction with IHA and the Office of Rural Health. So are there any questions at this time?
We can go ahead and advance to the next slide. In the essence of time, I'm not going to spend a lot of time on this particular slide, and just go ahead and move on to Abby presenting. But we will be seeking some input about some future projects. I'm going to tee that up and let Abby share some information. There was also contact information for individuals at IHA. At this time, I'm going to go ahead and turn it back to you, Abby.
Thanks, Karen. Okay. So in the process of talking with the Hospital Association about a carryover project, we have gotten into discussions about how we are going to transition the SHIP program altogether going forward for the next fiscal year. So that's what I would like to talk to you about. First of all, my name is Abby Garcia, and I am the State Office of Rural Health Manager. I've been in this position since February, and I have a long career history of working with nonprofits, community resource programs. I worked for an area agency on aging in a rural part of the state. So a lot of the experience that I have comes from kind of boots on the ground resource community programs. My position here at the State Department of Health is under the State Office of Rural Health grant, and that grant also includes SHIP. So in the past, the Small Rural Hospital Improvement Grant Program, which is called SHIP for short, comes from HRSA, that's Health Resources Services Administration, through the Federal Office of Rural Health Policy to the state offices of rural health, and then goes out to you all in a very small chunk to the critical access hospitals and small rural hospitals that participate. And so the eligibility for that program is 49 beds or fewer. So you do not, unlike Flex, you do not have to be critical access designated, but you do have to have 49 beds or fewer. And SHIP was created to assist all hospitals who are eligible to meet the cost of implementing data system requirements established under Medicare, and in using those funds to assist hospitals in participating in improvements in value, quality to health care, and those are in 3 different areas. That includes value-based purchasing, accountable care organization or shared savings, and then payment bundling or prospective payment system. And so critical access hospitals are eligible, and we have 35 in the state, and then we have several rural hospitals that have taken part or haven't. So the change that we would like to make is that we want to make the projects open to all of those hospitals instead of individually having to decide if your hospital has the capacity or time to do a small project. And so for many years, this has been the pattern, as you can see on the slide, of how the grant dollars have been used. And then each hospital has had to decide how to use the small amount of money according to the menu that's put out each year. And then ISDH has done individual contracts with each participating hospital for their project that was proposed. That has proven to be increasingly difficult to manage, all those contracts. And then the federal government, which is the HRSA and the Federal Office of Rural Health Policy, has encouraged for many years, has encouraged us to pool those resources to make the funding more effective and to show a greater impact. And so I was in DC maybe a month ago, and one of a whole half day of our presentations of the 2 days I was there was around measuring impact and showing that we're using the dollars in the most effective way. And so this is there encouraging us to do that. You can go on to the next slide. Yep. And so for the 2018 fiscal year, we are going to transition from giving the individual contracts to each hospital to doing one contract with the hospital association. That will give us the opportunity to pool the grant funds and creates a really great partnership with the hospital association. So SHIP is going to work through the hospital association beginning with this fiscal year. This will give us an opportunity to offer a variety of projects for the participating hospitals that will align with the investment activities in that menu, and as well as projects that are pertinent to you. So I think on Karen's second to last slide, which you received in the email from Becky, you will be able to see the kinds of things that we have talked about, but we also want to get some feedback from you, particularly about what you think you'd like to see that you may not have been able to do before because it was such a small chunk of money, or you didn't have the capacity. And so we want to tailor these projects and give you all the chance at projects that may have been out of reach in the past. This will also give me a better grasp on measuring impact, which is becoming more and more important at the grant level. We need to show that the grant dollars we have been given are being used in a way that truly impacts not just the hospital, but the community and the patients that are being served. Another thing that this will offer is a chance at doing some really creative and innovative projects that may not have been feasible before. And like I said, we really do value your input and feedback when deciding what kinds of projects that the Hospital Association will offer through SHIP. You can go on to the next slide. So I have received, I've been in lots of conversations with the project officer at HRSA and the task center through the National Rural Health Resource Center, and have found some really strong state examples of folks that have been pooling resources for years and some who have just recently decided to do this. I've been really encouraged to hear that they have, other states have felt the same way about the way SHIP had been managed up until now. And the state offices of rural health are increasingly being asked to provide more data to show impact and measuring how the grant dollars directly improve quality in the hospital setting. And so that makes these individual contracts much harder to manage, especially in Indiana, where we have over 40 hospitals that are eligible. States like you'll see here, Nevada, they have 11. And so that wouldn't have been necessarily as difficult to manage, but they've pooled their resources and have been doing projects together through SHIP for several years. I am also not an expert in the quality investment activities that SHIP funds, so it makes sense to put the experts, IHA, in the place to work directly with you in designing these projects and then implementing them. So these 4 states, Kansas, Alaska, Ohio, and Nevada, have pooled their resources and have had amazing success doing so. Kansas contracts with an outside firm in Georgia. I think it's a for-profit firm that provides the SHIP hospitals with technical assistance and education and training opportunities that fit within the menu investment activities. Alaska presented on a webinar to all the SHIP coordinators across the country about their very recent transition in the last year, and that has been very successful. Nevada contracts with their hospital association in the same way that we will be doing with Indiana Hospital Association. And then I have contact information for several of these SHIP coordinators in these states to seek out assistance as we go through this transition. So I want to make this as seamless as possible in really getting everybody's feedback and really taking into account what you all are looking for when it comes to these investment activities. We can go on to the next slide. So the application for the fiscal year of 2018 will come out next Monday, and then will be due on February 12th. Between that time, from now actually until the due date of the application, I will be reaching out to make sure that I have correct contact information for everybody and be available to answer questions as they come up. I may also have specific questions for you that pertain to your hospital as I complete the application, so I want to make sure I can get to the right person. And I will be participating in a webinar on December 11th that will provide technical assistance for the SHIP coordinators through the State Offices of Rural Health on December 11th. That will help us formulate some questions that we may then come out to you and ask. So Karen and her team and I and the rural health team here at ISDH are really excited about this. I think this is a better use of resources and will provide you all with more opportunity to participate and get engaged and get some really good resources and education and training, and so I'm really looking forward to it. I have one last slide with my contact information, so please reach out if you have any questions or concerns. I am available as much as I can be, and so I don't know if there are any questions now. I can't see the chat box, so.
I am not seeing any questions. Becky, are there any specifically to you?
Becky, are you muted?
She is not muted. She should be able to go ahead and talk. Becky, can you hear us?
Can you hear?
Mm-hmm. Becky, what about now? Well, I'm not sure what's going on with Zoom today. It must just not be our day. But I'm not seeing any questions coming in on my side. So if nothing comes in, I believe that is it for today. It is 12:30, so we are right on time. Becky, do you have anything? I think I'm seeing that you can talk now. Okay. She is speaking but cannot hear everyone, or cannot hear, you can't hear her, sorry. But we don't have any questions, so thank you all for popping on today for today's meeting. We will hopefully get some of these Zoom issues fixed for next meeting. Thank you all very much.
Thank you.